I'm going to talk about COVID-19 virus, which is spreading at an alarming rate throughout the world currently. In the following slides, there will be some real statistics with regards to the total number of cases and the deaths compared to 3 to 4 weeks ago and yesterday. When it comes to Italy, the total number of cases were about 470, which is about the number that we have on February 26th, which has gone up to 63,000 on March the 23rd, which is about 150 times increase in 1 month. Now, when we look at the deaths of Italy, there were total 12 deaths on the February 26th, and by 23rd March, it has come up to 6,077, which is about 500 times increase. And remember, India is at this mark currently. The healthcare workers are stretched out and the healthcare facilities are overwhelmed. You can see all these pictures coming through from Italy. Patients being treated outside the hospital in makeshift beds. This 85-year-old anesthetist, who was the anesthetist who performed the first ever heart transplant in Italy, has now been called back to work as a doctor in Italian hospitals. A team of Cuban doctors and nurses have arrived in Italy to help tide over the shortcomings of healthcare workers. Now, when you talk about United States, another big country, on March the 8th, the total number of cases were 541, and currently there, 2 days ago, it is 43,000. Another 65 times increase in 15 days. Again, remember, India is at this stage currently. The total number of deaths for 12, which is just about what we have currently, which has shot up to 553 in 15 days. Again, a 46 times increase. Now, if you look at the different states, just the New York State alone contributes to the New York City 25,000 total cases, which is about 50% of the total cases in United States. So it is very clear that the states that could not manage the initial cases well ended up being the worst performers. And look at this figure. There were about total of 210 deaths in New York City, and out of them, in the last 24 hours, there were 53 deaths. So 25% of all deaths happened in the last 24 hours. Now, WHO has warned that US could be the next epicenter now that the Chinese numbers are coming down. And as Trump is talking about lifting the lockdown, WHO is really concerned that this could become an epicenter. Spain, similar picture, 525, 35,000 now, 65 times in 16 days. Deaths from 10 to 2,300, 230 times. Now, this is interesting. 14% of all Spain's coronavirus cases are healthcare workers, doctors, nurses, and the assisting staff, which was about 12% the day before, shot up to 14%. Now, United Kingdom, similar picture, 460, 6,180 active cases, deaths, 10 on the March 12th, 335 by March 23rd, 33 times increase in 11 days, which prompted Boris Johnson to announce full lockdown, and the member of parliaments who are doctors started working back in hospitals in NHS, the UK health system. The healthcare situation in India, with large population and inadequate healthcare facilities and lack of awareness and sensitization of healthcare workers and public at large, along with inadequate manpower to do adequate case contact tracing, is an issue. Just look at this sample case. It's published in BBC News on the 24th of March. A doctor saw a patient with cough and fever in the city of Bhilwara in Rajasthan. Later, the patient was diagnosed having COVID. Within 2 weeks, 13 people from that hospital, which includes doctors, paramedics, between the ages of 24 and 58, have been tested positive. But look what happened within those 2 weeks. About 6,192 patients have visited the clinic where these doctors worked from 13 districts of Rajasthan and 4 districts, and another 39 patients from 4 other states adjacent to Rajasthan. What can happen in these situations? Classic example is one of patient 31 in South Korea. The patient who never went out of South Korea in the recent past, visited a C club, probably Chinese club, and had a car accident, was admitted in the hospital, was discharged home, attended a church on Feb 9th, developed fever on Feb 10th, had a buffet in a hotel on Feb 14th, attends another church on Feb 15th, and then the fever gets worse, and then she goes back and gets tested, and she is positive for COVID-19. But see what happened within this week. Within 1 week, she infected so many people by attending 2 churches. And now, about 5,000 infections in South Korea, which constitutes 60% of all cases in South Korea, come from this one single patient 31. Now, our situation. A senior cop, his son got tested. He did not inform the son's arrival from London and is tested positive. Now, look at this particular case. The wife, the police official himself, as well as the house help, all are tested positive. And the patient went out, got a haircut done, attended a family function, went to another district. So we do not know how many contacts are there out in the community. Quarantined man marries and 1,000 people attend the wedding ceremony. So the prediction is that at current rate there would be 30,000 deaths by the end of May. And going back to the graph that I have shown already, this is not something that we cannot expect. And there may not be any hospital bed available by the end of June. Now, what we need to do, what our team of experts suggest is we need to do robust case and contact tracing, coordinating with private sector as well for higher level of care, management of medical personnel, very important, personal protection equipment, provision for all healthcare workers, dealing with the social and economic aspects of long-term lockdown. Case and contact tracing is very, very important. The on-ground healthcare workers are certainly not sufficient. If a patient who landed on the March 18th could go unnoticed, that just means that we need more people to work on the ground. We need to involve ASHA workers, ANMs, NGOs, everyone who can help us. And the more important aspect now is, can we actually ask airlines to call all the passengers who landed from their respective airlines via international flights, because they would certainly have a robust contact mechanism of their passengers. These are the suggestions from public health specialists from central institutes, those who are working abroad, and those local experts who have experience of working with UNICEF and WHO. Contact tracing of all cases needs to be done, and it has to be strict and supervised isolation, case mapping, fumigating of all hotspots, case tracking of all probable secondary transmissions, line listing of all hotspots, suspected secondary transmitted cases, and isolating and testing them properly. For all positive cases, do we have case tracking maps? Have they been audited by another epidemiologist? Have they been interviewed personally? Have the hotspots been fumigated? Have the families and contacts been interviewed for the symptoms? Did we test all of them? Do we have a list of all contacts? I know the manpower and other resources are scanty, and that is the very point that we are trying to say, that we need to act together along with the government. And for the higher level of care, we need functional ventilators. Having just a ventilator is not enough. We need an intensivist, the ICU nurses, biomedical engineers, oxygen points and oxygen itself, dialysis units when the patients really get sick, isolation facilities, and more importantly, personal protection equipment for all the healthcare professionals. Do all the ICU beds that are mentioned in the recent document meet this criteria currently? And what do we need to do to make them functional now. Coordinating higher level care between government and private sector. Again, private providers should come out with the designated COVID units. Most of the ICU care should be dealt in institutes or private setups. Only government institutes cannot cope the projected caseload. We need to engage doctors, healthcare workers, and social work professionals. SPM faculty and postgraduates from all private medical colleges should be involved in the ongoing care. MSW students, faculty can help us with on-ground activities. Again, the same point, only government institutes I don't think will cope with projected caseload. Any case of fever from hotspot or high-risk district should be tested for COVID and to check for the community distribution. The opinions of team of public health specialists in our state and from outside states to formulate local policy. All ICU patients must be tested in high-risk districts. From the high-risk districts, we need to test more and more. Hospital response, they need to have careful use of their available healthcare workers. The use should be staggered. The supply chain management should be looked into. We have to save our saviors first. Line listing, mapping every resource by the name, date, time, and roster is very, very important private setup as well. PPE supply chain is very, very important. The medical fraternity will be unprotected soon. There will be no one to take care of the sick if that happens. For example, the government industry, a town in Tirupur, there are about 246 textile mills and 3,000 plus government manufacturers and exporters of textile. We need to cordon that city off, let them work day in and day out, and get PPEs manufactured as soon as possible. N95 masks is another issue. Whether it is in Thane or outskirts of Pune, we need to get them manufactured, and we need to get some designated flights to cargo them back. We need a lot of government help in this regard. Remember, healthcare workers, 14% of new cases in Spain. We need to partner with doctors and paramedical staff and industry. We need to share the expertise of private healthcare providers, identify the limitations of existing systems, and plan for the worst case scenario. Just remember, it will not spare anyone. Nobody is immune. There is no treatment or vaccine. Prince Charles is recently diagnosed positive with COVID-19. Contact trail can be anything. Kanika Kapoor, Bollywood singer, came in contact with Vasundhara Raje, President of India, Union Minister, Chief Minister. So, no, we really need to step up our on-ground contact surveillance. We also need to look at various ways of making makeshift hospitals. Now, this center in Ottawa has been makeshift from a hockey arena to temporarily work as a coronavirus assessment center. A conference and exhibition center in Wuhan has been made into makeshift hospital for isolation facilities. Now, this again is from Wuhan. 30 hours after birth, baby who has been tested positive for coronavirus, a nurse looking after the baby. Meanwhile, medics in countries like UK, Iran, Italy, and Australia have reported that they do not have enough medical equipment to fight the virus. Dr. Dinesh Parmar, chair of Doctors Association, told BBC, "We have had doctors tell us they feel like lambs to the slaughter, that they feel like cannon fodder. GPs, the general practitioners in the society, tell us that they feel absolutely abandoned." Meanwhile, in India, Mumbai Crime Branch has seized 25 lakh masks from godowns in Andheri and Bhiwandi, including 3 lakh N95 masks, total worth 15 crores. Masks worth 11 crores missing from Jaipur's premier SMS hospital. The clock is ticking. Time to act now, otherwise it will be too late.